today. As everybody, welcome here today. Aside from just our city clubbers, we've got some outside guests who are joining us to hear Julianna Lower from Cayuga Medical Center, who is the stroke coordinator at that facility. Some of you who are physicians may even have worked with her when she was in the emergency room or ICU. So without further ado, I give you my daughter, Julianna Lower.
Okay, I'm going to mute everybody. Julianna, please unmute yourself.
Oh, okay, yeah, I just want, I was down there.
Julianna, you need to
There we go.
unmute
Okay.
yourself.
All right. Can you hear me now?
Yes.
Yes.
Okay. Okay. Perfect. So yeah. Thank you for having me, and good afternoon to everybody. So yes, I'm the stroke coordinator at Cayuga Medical Center, like my dad said. And today we're going to talk about stroke and how to recognize it and how to respond. And if this is, if there's physicians, this is probably not going to be terribly new for those of you that are healthcare providers. So hopefully I do a good job.
That's a small minority, so you're good.
That's good. Also, be warned, I do share my office with 2 other people, so if it gets loud in here, I apologize in advance. So just as a, I'm gonna have to share my screen, share. All right. So to start off, I'll just get back to my first one. So yeah, Be Fast for Stroke is the name of it, recognition and response. That's not all what I wanted to do. Let's present. There we go. That's better. All right. So just to start, introductions. So the objective stage is to define stroke and what it is and what basically the three different types of stroke. We're going to discuss why we say time is brain. And most importantly, learn the signs and symptoms of a stroke and what to do, because a lot of people aren't sure. And then briefly discuss diagnosis, treatment, and prevention. And my one disclosure is that, like my dad said, I work at Cayuga Medical Center. I'm going to be mentioning other things like the American Heart Association, SUNY Upstate, University of Rochester. I don't get a dime from them. But just those are my very brief disclosures before we start. So what stroke is? So basically, blood vessels that are carrying blood to your brain, so they either can become blocked, we call that an ischemic stroke, or they can rupture, which is called a hemorrhagic stroke. When that happens, the brain is not getting enough oxygen or nutrients, and the brain is incredibly greedy and takes about 20% of your blood supply at any given time, and it needs sugar or it can't function. So yeah, it is a greedy little diva. So if it doesn't get enough oxygen or nutrients, parts of it can die over time. And when I say time, I mean minutes and seconds, and we'll talk about that in just a few minutes. And it is the 5th leading cause of death in the US, and it has been for quite a while at the moment, or it used to be number 3 was COVID there for a while, and I think it still is. So we'll talk about acute ischemic stroke first. I have to warn you also that I am not an anatomist. I do know how to draw, but I do not know how to draw anatomy, so it may not be perfectly to scale. So ischemic is the most common. About 87% of strokes are ischemic stroke, and a blood clot either forms within the blood vessel itself, or it can travel from somewhere else in the body, usually the heart, and it goes up into the arteries in the brain. And as the arteries get narrower, because they're kind of like tree branches, the clot can get stuck, and it stops the blood flow to the rest, to that part of the brain that it's supplying. So yeah, so that yellow stuff is, I say cholesterol, it's arterial plaque that's caused by cholesterol, but when primary doctors nag patients about it, this is what they're talking about. Yeah, so the grayed out area is parts that aren't getting enough oxygen, and so they start to die off over time. And that is what an acute ischemic stroke is. And hemorrhagic, so they're not as common, but they are more deadly. So 13% are hemorrhagic strokes. A lot of times they're caused by an aneurysm, and a lot of you may have heard that term before. An aneurysm happens when there is a weakness in one of the blood vessel walls. The blood pressure going through it will make it larger over time. As it gets larger, it gets thinner, and eventually it will rupture and leak blood into the surrounding area. So yeah, those empty spaces, so that's the high blood pressure. Why, when your doctor warns you about high blood pressure, this is part of the reason why. I mean, there's a lot of reasons, but this is one of the big ones, is because it can dramatically increase your risk of having a stroke. And then transient ischemic attack, one that people may not be as familiar with. It's also called a TIA. American Heart Association used to be called a mini stroke. Now they've stopped doing it. And the reason why they stopped doing it is because when people heard mini stroke, they wouldn't take it very seriously. They'd be like, oh, it's just a mini stroke. That's not really how it should be talked about. It should be instead thought of a warning stroke. And the difference is that the symptoms, some of which we'll talk about here in a minute, they only last a short period of time that can be less than a minute up to a couple of hours. But because the mechanism is exactly the same as acute ischemic stroke, it's a warning that you may have a stroke. And in fact, 1/3 of patients who have a TIA will go on to have a stroke within a year. So it's kind of like, if you're not trying to mitigate risk factors, now is the time. And then among stroke patients, 7 to 40%. The like literature like that always has a humongous range. 7 to 40% report having had a TIA first, if they even know that it is happening, which we'll talk about that in a moment. So time is brain. So this lovely graphic that I found from the American Heart Association. So basically, over time, this is what I mean by seconds. In 1 second, when someone is having a stroke, and when I say stroke in this case, I mean a big stroke where a large vessel is blocked, 32,000 neurons per second. And neurons, basically, it's a brain cell is the most simple way that I can put that. And so yeah, so 32,000 per second, 1.9 per minute, million per minute, per hour, 120 million, and 1.2 billion per stroke for neurons. I'm not going to read every single one of these to you, but in terms of the amount of brain that's lost every second that ticks by, that's why we say time is brain. We say get to a hospital. We try to get treatment quickly if it's, when we can. This is why, because with every second, your brain is aging 8.7 hours, all the way up to 36 years on a stroke. Accelerated aging, we call that, of the brain. So that's why we move quickly. We be fast. So be fast, as you may have surmised by now, is an acronym. It stands for balance, eyes, face, arm, speech, and time. It used to be just fast. You may have heard fast before, which is still true, but they added the other two because they tend to get missed. So balance. So all of these, it's always sudden. It's a sudden change because other things can look like a stroke and be kind of gradual. So, if someone has like a brain tumor, for example, some of the symptoms may be similar, but they'll come on more gradually. Of course, if you're not sure, the thing to do is to get to a hospital, call 911. So balance, a sudden loss of balance or coordination. Maybe the person is walking funny, running into the walls, dizziness. And dizziness is really tricky because so many other things can cause dizziness, but it's often dizziness in conjunction with something else. So these are all symptoms of what we call posterior stroke, which is a stroke in the back of the brain, the part called the cerebellum, which allows you to be able to balance, coordinate movements. And then hemorrhagic strokes, these can be present with hemorrhagic strokes too, those less common but more deadly ones. Additionally, and I just stuck this into balance because it didn't really fit anywhere else. So worst headache of my life, nausea and vomiting, sleepiness and confusion, again, usually with a pretty quick onset, which can differentiate between that and other kinds of neurological problems, but it's best to err on the side of caution. And then eyes, just a sudden visual loss in one or both eyes. Now we test for what's called a visual field cut. I mean, I wouldn't expect anybody to know who's not a doctor or who doesn't do this to be able to test for this, with your family, with yourself or your family members. But what can happen, especially when the stroke is in the right side of the brain, my young lady there with those dark stripes over her eyes, when someone's had a stroke on the right side of their brain, it will knock out half of their visual fields. So they won't really be able to see anything coming from the left. And just as a point of interest, like the clock picture that you see, that's if somebody's had a right-sided stroke and you ask them to draw a clock, that is often how they will draw it because they don't see that left side, and they don't know. They also don't know. They may not believe that they're having a stroke. That's another thing about right-sided strokes. And what we call partial or total gaze palsy, which again, when we have the patient following fingers with the eyes, they'll either won't be able to move from having their eyes stuck this way, or they'll only be able to get halfway. Again, wouldn't expect anybody to test their family members for this, but that's something that we would look for people that are having a stroke. F, facial droop. So now we're getting into the classic symptoms that a lot of people are familiar with. So you say, show me your teeth. and one side will droop. Or like sometimes you'll see more teeth on one side than the other. Now this gentleman has a pretty severe and obvious facial droop. So yeah, uneven smile, only one side of the face moves. And then one trick that we use when it's really subtle is to look for that line between the nose and the corner of the mouth. You can see on this gentleman, it's disappeared because of his facial droop. Sometimes that's our only sign that of facial droop. It's usually not this obvious, but yes, facial droop is another key. And then arm weakness, if they ask them to hold their arms out straight, we have them close their eyes, you don't have to. And then one arm is slowly gonna drift down, or they may not be able to lift it at all. So one-sided arm weakness, one-sided leg weakness. And then speech, there's a couple phrases that people use. The one that we do is often, you can't teach an old dog new tricks, and we like that one because there's a lot of vowel and consonant sounds in it, and also it's an adage, a lot of people already know it. It's, you know, it's an idiom, a lot of people are already very familiar with it. So any difficulty forming words, and also if they can't understand to comprehend and follow commands, that's another way that another part of your brain that to actually process words, process language, can be damaged, and they may not be able to follow what you're saying. Also a sign that they might be having a stroke. And slurred speech, maybe they can get the words out, but it's garbled, it's unclear. That's a red flag for sure that someone may be having a stroke. And then the last is T for time. The time is, again, time is brain calling 911 quickly. And the reason why we have people call an ambulance is because they're stroke experts in the pre-hospital setting. They have a lot of expertise, and they can call the hospital and let the hospital know that you're coming. Which can get everybody ready, get to the hospital faster, get seen faster, and the hospital will be expecting somebody coming in with a stroke and can plan accordingly. And then the other piece for time is that it's really helpful if you know when the person, if it's you or a family member, when they were last known well. And we'll get to why that's important in just a minute. But yes, knowing when the symptoms started, knowing the last time the patient was seen without symptoms, the people at the hospital are absolutely going to ask you that question. So if you know the answer, it is profoundly helpful. All right, so recognize the symptoms, called 911, the ambulance is brought to the hospital. Well, then what happens? So you go to the emergency department. The first thing that we do is a CT scan. And the reason why we do that is we're looking for blood. We're looking for bleeding. The person that you see on the left there, that's basically what a normal scan looks like. What you're seeing is a cross section, like from here down, from here across the head like that, and you're looking from the bottom up. So right is left, left is right. It gets a little confusing. And then the person on the right, this is pulled from a real person scan. This gentleman, he's fairly young. He was 48 years old. He came in with those weird symptoms: dizziness, confusion, nausea, vomiting. Came in, and that's what we saw on CT. And incidentally, his blood pressure was 223/133. Normal is, I mean, the guidelines change a lot, but 110/70 is what we like to see in people. So 223/133 that's what I'm talking about when we say high blood pressure in the kinds of strokes where they're bleeding. Hemorrhagic strokes, it's often really, really high. And then on the right is just a picture of a CT scanner. If you haven't seen one, it's not an MRI where you're completely enclosed. It's just a little donut that you go through head first. The entire thing doesn't take very long. But yeah, we're looking for blood, and blood tends to show up bright white. Things on X-ray that are dense tend to look bright white. So the skull is very bright, as you can see, and blood tends to show up very bright as well. And then they may do a CT angiogram too, where they inject dye in, and they can see clots that way. But the CT, just the plain CT, is the very first thing and the most important that we get. And so yeah, we're looking for blood, but also we're looking to not find blood. And the reason why I say that is because if the person comes in quickly and there's no blood on that CT, you might be able to get what we call thrombolytics or clot busters. So it's a medicine that can actually break that clot apart. It's called alteplase. Some places use tenecteplase. And then this is why we ask about last known well, because this medicine has to be given within the 4.5 hours since that time. And beyond that, and it's the risks aren't really worth it. And so that's kind of the cutoff, and why we say, you know, go fast and get into the hospital. And then the major side effect, as you might imagine, is bleeding, because it doesn't know any better between clots in your brain and clots elsewhere. It's just going to break apart clots in the body. So Only certain people can have it. If you've had recent surgery, you can't have it. If you've ever had brain bleeding, you can't have it. And then the little infographic I made on the right is just kind of the efficacy and what happens. So those dark green guys that get it, there's 100 little guys in this picture, but the dark green ones that get to normal or nearly normal, light green, they get better. For a majority of them, there's no change. The pink guys have bleeding initially, but it doesn't necessarily cause problems. And then the red ones have more severe bleeding. So yeah, it's a dangerous medication, but for the people that it does help, it's pretty dramatic, and it can really it can change lives for the better. So that's one thing we consider. Clot retrieval is another thing. We don't do it here at Cayuga Medical Center. We would send somebody to a larger tertiary center, an academic center. Usually it's University of Rochester or upstate. I should have said upstate, not Strong Memorial. So yeah. And then the pictures that you're seeing on the right that's again is a real before and after of a patient who he was young too. He was about 48. He came in and his friends thought that he had heat stroke because he fell over and he couldn't stand back up again. And this is on the right side of the brain. So he didn't believe that he was having a stroke, and EMS had to convince him to come in. But they were able to help him, as you can see, and it's pretty incredible. It's pretty dramatic when they can actually help. So that big tree you see at the bottom is now all the blood vessels that can now supply that part of the brain again. He had a pretty good outcome. He was discharged home with outpatient physical therapy. So yeah, so they go in through, they just use a needle to get usually into the groin, and then they can feed the wire up into like through the blood vessels up into the brain, and use a clot retriever, which kind of looks like a little slinky, and they can pull the clot out. That can be done up to 24 hours since last known well. So even if somebody is not within that 4.5-hour time period, it's still really important to get them to the hospital because they might still be able to have intervention. Yeah, so and then people get admitted. If you've had clot busting medications, you go to the ICU because you need to be watched for 24 hours and get frequent monitoring to make sure that you're not getting any brain bleeding. May have an MRI because it's a better picture for the stroke itself than a CT. Again, CT is really good at finding blood, but in terms of seeing a stroke, MRI is going to be a much better picture. Cardiac monitoring in case there's something else going on, because the mechanism that causes stroke can also cause coronary artery disease. So they're going to make sure that there's nothing going on with the heart that they don't know about. So getting an echocardiogram, which is an ultrasound picture of what your heart's doing. And then getting set up with rehab, because if you have some of these deficits from a stroke, if you continue to have weakness on one side or difficulty speaking or difficulty swallowing, lives are going to change and need support and need physical and occupational therapy to start getting better and maximizing quality of life after having a stroke, regardless of what the deficits are. And then discharge planning, again, for the same reason, because often things are quite different when someone has had a stroke and they need to adapt. I'm going to talk about prevention real quick. So basically, yeah, managing high blood pressure, high blood sugar if you have diabetes, that can also wreak havoc on blood vessels. Getting cholesterol under control, atrial fibrillation, which I'm not going to go nuts on today, but just it's a heart rhythm where the top of the heart kind of wiggles around instead of pumping efficiently, and it makes blood kind of gather. And when blood gathers, it clots, and when it clots and it goes somewhere, it goes up into the brain, can cause a stroke. Quitting tobacco, exercising, eating healthy foods, limiting alcohol, and then avoiding drugs, particularly cocaine, because cocaine makes your blood vessels do that. And so it can definitely cause problems with stroke and cardiac disease too. And that's it. That's what I have for you. Down and dirty stroke. Does anybody have any questions?
So go ahead, Ed.
I understand that there are no unused parts of the brain. And so when I had my stroke about 2 years ago, I had to teach other parts of the brain to pick up and do things. And I still have a couple of crazy things happen. When I stick my right hand in my my right ear, I can do it faster and more accurately than my left hand. But if I do both at the same time, it's very accurate and very fast. So two parts of the brain are working here. Is that right?
But you end up other parts of the brain can take over to some extent when you've had a stroke, and that's part of what the rehab piece is learning how to kind of to the extent that you can relearning how to use other parts of your brain and adapt.
I
to
had
what's
all
going on.
three
Thank you for
kinds of
sharing.
therapy.
Yeah, I believe it.
The only thing that I have remaining is my left leg. I have to be conscious of lifting and planting my left foot so I don't scuff my heel. And the second thing is, you may not hear it, but my speech doesn't feel exactly right.
Yep. Thank you.
What is the mechanism that causes the blood pressure to go up so high when there's is it hemorrhagic stroke?
The hemorrhage would have the high blood pressure. I mean, this might be a better question for one of the, if there's primary doctors here today. They used to attribute it to sodium. That's not true for everybody. There's maybe some genetic components, stress, and yeah, I mean, like if you exercise can help bring it down, eating right can help bring it down. But as far as the mechanism for what causes it in the first place, then I know that if there's anybody who is a primary care doctor in the audience that can maybe answer that question a little bit better than me.
Well, I was wondering, Ken, are you asking what causes the blood pressure to be so high at the time of a hemorrhagic stroke?
Yes. Is that a reaction or a causative factor?
The problem with high blood pressure in general is that you often don't know it's an issue until it does something like this. It's called the silent killer because you may not have any idea that your blood pressure is that high. It has to get pretty high in order to cause symptoms a lot of the time. So not just, I mean, hemorrhagic stroke is kind of a sort of worst case scenario when it comes to really high blood pressure in an immediate sense. But it can get really, really high. Your body's it happens slowly and your body just sort of gets used to it. And so in terms of bringing that gentleman's blood pressure down, when he went to Rochester, I'm sure they had to do it really carefully because his brain is used to having that blood pressure in it, all the time. Probably in his case, his blood pressure was that high. In terms of things that can make it go acutely high again, drugs can definitely do that. Cocaine for sure can do that. But for all we know, his blood pressure was always that high. The problem with the emergency department is that for everything, the ER sees people in a vacuum. They don't necessarily know them. They can't go back and say, well, unless they've been there recently and they're, they come a lot, they may not know, that their blood pressure is super, super high until it causes big problems.
Thank you.
Julianna?
Yeah.
Am I mistaken? At one point, wasn't it indicated that one of the first things to do if a person was having a stroke would be to give that person aspirin?
That used to be true. Yep. But we've gone away from that because it's more important to get them clot busting medication if they're appropriate for it, and they will get aspirin eventually. Most of them will. They'll get aspirin and they'll get another drug called Plavix, which is it works similar to aspirin. But the other thing that we have to be really careful of when someone comes in having a stroke is a lot of them can't swallow, and so in order to get aspirin, you have to be able to swallow. And if you can't, and you choke and water and something else gets in your lungs, well, now we got two problems. We got a patient that's having a stroke and now they have aspiration pneumonia as well. So they may get aspirin, but they might not be getting it by mouth, if you know what I mean. So, so the short answer is yes. Longer answer is not quite. So yes, they will get aspirin eventually if they're not bleeding. But yeah, we used to do that. We used to give aspirin like immediately, and we've kind of gotten away from doing that. They do get it eventually, and Plavix, but not right away. But it is important.
Julianna, I've been retired for a little while, but I know there was controversy or some degree of lack of consensus about whether thrombolytic agents would be given systemically, intravenously, or introduced intra-arterially? Is that?
Yes, that is, yeah. So you can get it intra-arterially, but I will say this too, is that when we give people thrombolytics, because we only do it systemically, we only give it IV because we're not we're a primary stroke center, not a comprehensive stroke center, which means that we are able to give it IV and then monitor the patient afterwards. But we will give it, we'll do what's called dripping and shipping, which is we'll give them the thrombolytic and then ship them out either for intra-arterial thrombolysis or clot retrieval. But they can
Right.
have alteplase first. But which one's better? Yeah, that I'm not sure of, because I'm not sure if any two providers ever agree on stuff sometimes. But yeah, that's definitely something that it gets done. But as far as which one's more effective, I could not tell you.
We have a question for Persephone.
Oh, yeah, Persephone. Yeah.
Persephone. Thank you.
Any guidelines? You've actually got me totally terrified here, but
Sorry.
I live alone. Any guidelines for? So I'm wondering, like, is the victim typically aware? What, is there a simple elimination list? Like, I get the nausea, I remember that.
Right. Yeah.
Like, are people typically aware on their own?
If
what
it's
might be
something
happening?
with like the classic fast, like face, arm, speech, those
Yeah.
ones, they often know that that's what's going on,
Uh-huh.
or they know that something is, that they're aware enough to know something pretty crazy, not good is happening, and can call 911. If you live alone, I mean, having one of those like life alert buttons is not the
Yeah.
worst idea in the world, because with any kind of stroke, it can cause you to like fall down on the ground. And I've fallen and I can't get up. It's a cliche, but it's true. So
Yeah.
they use that phrase back in the 90s to sell, I don't know if it's life alert or some other kind of like clicky help me button, but those are really nice when people live alone. So with ischemic stroke, they're more likely to know something is going on. Hemorrhagic, unfortunately, those are the ones that will sometimes be, and again, I don't mean to scare anybody, but often the hemorrhagic ones are the ones that are found down. So they just, yeah, it happens, and sometimes
But that's the
it.
less common. So
That's
it's
the
a
less
common
common. Yes,
thing.
the
You might,
ischemic is a lot more common, which is why we kind of teach people the
Right.
classic signs too, of how to recognize it. And and again, I don't mean to scare anybody, but like all the things that we measure in terms of time metrics and hurrying in the hospital, none of that matters if people don't know what to look for in a stroke, which is why we do this public ed stuff, so people can recognize it and say, okay, that's what it is, and we need to get to the hospital right away. Because so many people come in and it's been going on for hours, it's been going on for days, they've woken up with it, it's still good to come in, but like there's only so much we can do at that point. So yeah.
I want to put a real plug in here, as my mother lived in her own condominium until, she died at her home, and was living at home up until when her health failed rather rapidly. And we did get her hooked up with one of those necklaces that had the button on it. And on 2 occasions, it proved to be invaluable and gave great longevity because we were able to get prompt treatment. So I will put a plug in for those devices from personal experience. My mom died when she was 91 and was able to live at home the entire time. So it did make a difference when we had those occasions.
yes, I see it in my future, but I'm hoping I'll know when it's time.
Frank? You're muted, Frank.
You're muted, Frank.
I have a friend who recently fell on the ice of Cass Park, and there was nobody there, but he was wearing an Apple Watch.
Ah, right.
Yeah.
And the Apple Watch hit something, his arm went down, and it asked him, "Are you all right?" And you're supposed to disarm it by pressing 1. Well, he couldn't do that because he had a concussion. And so it called 911 immediately, and also called 2 of his relatives. One was in California and one was in Ithaca. So he thinks that the Apple Watch saved his life because it was like 10 degrees in an area of Cass Park that nobody was there. So it's not just the button,
That's
but there are these
better,
new
yeah.
technologies.
Yeah, that's better. That'll be better, yeah.
So I didn't want to give a plug for Apple. I don't wear one. Maybe I'll get one.
Ed's got his on.
Uh,
That might be what Heidi has.
Yep.
But she said she has to be.
Do we have other questions? Bud,
Yes, Julianna, I've had a couple of TIAs, and I was driving on both occasions.
Oh,
First time I had no idea what was happening, so I kept on driving until I thought I shouldn't be, and pulled into a McDonald's, and I had to practice giving a message on my way into the counter where I asked for an ambulance. But what is the difference out of this experience? By the way, I had incredible, the first time I was taken to Syracuse, upstate. The second time, right here, Cayuga, my care at Cayuga was way superior, just absolutely superior.
Good.
But I still don't know what the difference between a TIA is and a full-blown stroke. Is there a black and white, or is it just a big continuum? How does the care differ?
TIAs, the symptoms aren't going to last. So because the T is the transient bit. But yeah, I mean, it is a continuum. The mechanism is the same. What happens sometimes with a TIA is that like a clot will get stuck, but then it will kind of dissolve on its own, and then the blood will go through, and then you won't have the you may not have the symptoms anymore. But yeah, I mean, that's the difference in treatment. We don't give big gun thrombolytic clot busters on patients that have TIAs. If they resolve spontaneously, which they do by their very nature, then we're not going to give thrombolytics. But we don't always know when someone comes in. We have to assume if they're still having symptoms that they're having a stroke. We can't say, well, we're going to wait and it might be a TIA. Like we can't afford to do that. We can't, and because the mechanism is exactly the same. So when you come in and you say, well, this started half an hour ago, well, we're going to be screening you for thrombolytics because we don't know in that moment,
Right.
if it's a TIA or if it's a stroke, and we can't assume it's a TIA. And because again, the mechanism is exactly the same. As far as getting treatment for a TIA in the hospital, like they'll still want to put you on, a blood thinner like aspirin or Plavix, do an echocardiogram, do an MRI maybe to make sure that you didn't have a stroke at some point, because there's plenty of people, again, that we can teach you the signs, but some people if it happens in the middle of the night, you might not know. Yeah, I don't know if that answers your question.
I think so. Thank you.
Got another question. Several people who've had strokes wind up with a seizure. Now, what happens when a seizure happens?
The people that have seizures are more likely to be the ones that have had a hemorrhagic stroke. When the problem with your skull is that there's really nowhere for anything to expand. Your skull is a rigid box. So when you get anything in there that's not supposed to be there, like blood, then the brain will try to expand and will have nowhere to go. So what that can do is that can cause several things, including the dizziness, the confusion, the severe headache, vomiting, and it can cause seizures as well. But yeah, so you see that most often with a hemorrhagic stroke, and you'll see it sometimes too when someone has a disease where we call it demyelinating disease, but basically those wires, those connections, they have it's almost like wire insulation on them. If that starts to deteriorate, then you can get some basically electrical discharge between them, and you get a very disorganized brain activity that can cause a seizure. And that can be you can get seizures for a lot of different reasons. Besides having a seizure disorder, in kids, you see them when they have a temperature change with a fever. Doesn't mean they have epilepsy necessarily, but yeah, there's a lot of things that can cause seizures in people. But yeah, usually often see that with hemorrhagic strokes, so they're more likely to get anti-seizure medications when they come into the hospital.
Interesting.
Bob Barlow, you had your hand up a couple times.
Unmute. Bob, unmute.
There we go.
There, all right.
Okay. I have atrial fib and I'm on Eliquis, which is a wonder drug. I hardly, and I'm grateful for it, extremely grateful. It works. But that means that I couldn't take a blockbuster if I had a stroke.
Yep, that's correct. Yeah, so people so you fall into one of those categories of folks that are not going to be getting a thrombolytic or a clot busting medication. If you're on Eliquis, if you're on warfarin, Xarelto, so these are all blood thinning medications. So yeah, and Eliquis is one of them. Which again, in your case, I'm sure you're getting it to prevent having a stroke. But yeah, you would unfortunately not be able to get thrombolytic therapy. Although if it was a bigger stroke, then you'd still be eligible for getting clot retrieval if it was appropriate in your case. So there's still treatments that you could get if you were having a stroke. But yes, you're right. No clot busters for you.
My wife had atrial fib and she was on warfarin for years. And had stroke, had blood clots galore.
Yeah, it doesn't always
throughout her body despite warfarin.
It doesn't always work perfectly, unfortunately. And so, also some people are more prone to getting blood clots too. There's certain, I don't know if she had any diseases that make people more prone to blood clotting, but there are certain things too that can make you more prone to having your blood clot.
So I woke up one morning and she had a massive stroke.
Oh man.
And never did recover.
That's too bad.
Yep.
We're coming on 2 o'clock. Peter Davies, you've been raising your hand.
I have a question about dizziness. You said it's one of the symptoms, but you can be dizzy, I think, from other things.
Yep.
How come
Numerous.
If one is dizzy, how can you tell if it's a likely stroke or something else?
You can't always, which is why we hate dizziness, because it's a vague enough symptom that it could be, you're right, it could be other things. But I mean, if you're dizzy and you go to the hospital, that's your safest course of action, because dizziness can also be caused by, atrial fibrillation if you don't know you have it, and then you get it and like sometimes people know they're in atrial fibrillation and sometimes they don't. But there's a variety of cardiac conditions too that can cause dizziness. So unfortunately there's plenty of perfectly emergent things that can cause dizziness. So I would always counsel people to go to the hospital if you're not sure. But yeah, sometimes dizziness can happen in conjunction with other things when someone's having a stroke, but I wouldn't count on it. If you're dizzy, at least call your primary doctor at the very least. But I would tell you to come to the hospital.
I can probably field that question, having that was in my specialty. So dizziness as an isolated symptom, as the only symptom, would rarely, if ever, be caused by a stroke. Stroke's going to always have some additional symptomatology. Dizziness, and then if dizziness is true vertigo, a false sensation of motion, a feeling in any number of descriptions, if there's a feeling of motion when indeed it's not happening, most vertigo is of an inner ear related cause. But isolated dizziness with no other added symptoms is unlikely to be from a stroke.
Okay, well, I'll give you my example. I was walking down a corridor at work and suddenly I felt dizzy. I thought it would fall down. I had to sit down. It lasted about 30 seconds to a minute and then went away.
Never had it again.
No, well, not within a year or so.
Okay.
Yeah.
Well, that's a perplexing one. I don't have an immediate ear-related cause of that one. It might have been a very isolated TIA, but that's hard to give a direct answer to.
Before we wrap it up here and our guests leave, I want to just point out that if you take a look over in the chat window, I've sent everybody a link to the YouTube channel. That YouTube channel is where this video will be posted. And so if you have friends, family, associates, people you'd like to share this with, this material will be available within about 48 hours after today's presentation. You might want to copy and paste to a text message or someplace, because after you close your window, this will disappear. Secondly, let's give a great thanks to Julie for her presentation.
Thanks for having me. It was fun.
Thank you so much.
Yes, enjoyed it.
Welcome.
Thank you. Thank you, Julie.
Bill, I neglected to ask if you had any COVID updates. It seems like things are somewhat on the mend.